and welcome to Module 66. We're in Unit 12, and this is Anxiety Disorders, OCD, and PTSD. Here are your learning objectives, and here is your vocab. All right, so we're talking about anxiety disorders first, and anxiety is just a part of life. Everyone experiences anxiety at some point in time, a test coming up, a big event in one's life, whatever. So we're trying to tease apart what is typical and what is atypical or clinically significant. So anxiety disorders, and that's an umbrella term, are characterized by distressing and persistent anxiety that creates maladaptive behaviors in some cases to reduce that anxiety. So we're talking about generalized anxiety disorder or GAD, panic disorder, phobias, agoraphobia, and social anxiety disorder. There are two other disorders that involve anxiety, but since the DSM-5, they have been categorized separately in their own category, and that is obsessive-compulsive disorder, OCD, and post-traumatic stress disorder, PTSD. So generalized anxiety disorder is where a person feels a constant state of tension. They're always apprehensive. Their autonomic nervous system is always on a heightened. And so the person really is unable to identify any sort of specific trigger. They must experience this heightened state of anxiety for 6 months or more in order to meet the criteria for the diagnoses. And generally by age 50, the symptoms have decreased significantly or have completely gone away. It's just much less common in older adults. Generalized anxiety disorder can lead to other disorders as well, especially if not treated, because the person becomes likely, the most common one is major depressive disorder. So they become depressed because they're unable to function in regular everyday life because the anxiety is so crippling. This person might experience inability to sleep, distraction, might be irritable, and these are all because of this excessive anxiety, that's this constant thought process going on in their head that they can't stop. Panic disorder is an anxiety disorder where there's unpredictable, minutes-long episodes of intense dread, where the person experiences terror, and that could come in a variety of physical sensations with like shaky hands or numbness or feeling chest pains or problems breathing. And these are extremely terrifying sensations where the person thinks that they're dying or something is very wrong, and they usually last about 10 minutes, and then when they're over, the person is so scared by what happened, they become worried about when it's going to happen again. And so they'll start associating where it happened with the panic and start avoiding places like that, whether or not it had anything to do with it, because sometimes a panic attack just occurs and it's not because of the location. So in people who get severe panic disorder, that can lead to agoraphobia, where the person fears wide open spaces or crowds or public areas often because they are so worried about when they're going to have another panic attack. That leads to this fear of just going out. And so they stay in their comfort zone, which tends to be their home. Phobias are specific fears, persistent, irrational fear and avoidance of a specific object or animal. It could be heights, blood, enclosed spaces, or any sort of specific item. Social anxiety disorder is an intense fear of social situations that leads to avoidance of those things. So The person is very overwhelmed with thoughts that people are thinking things about something they did, said, the way they walked, what they wore, literally anything. The mind can think of all sorts of things, especially if it has some sort of anxiety disorder. And so the person avoids those things, again, to reduce that anxiety. Obsessive-compulsive disorder. So remember, it's not under the category of anxiety disorders in the DSM, even though anxiety is an important component of OCD. And I want to say, just like anxiety is commonplace, that we all experience anxiety at different points in our life, we all can have obsessive thoughts or offensive thoughts that bother us, or we can have compulsions things that we feel are like things we just have to do. And I want to be really careful, and I can't stress this enough. I want to make sure that we are not using the term OCD to describe ourselves, to just say, oh, well, I like things just so. No, they have to be in this particular way for me. Or it drives me crazy, like I want it to be like this. Before a test, I make sure this is just so, or my room, I have it just like this. That is not OCD, and we are doing a great disservice to all types of mental health issues, but particularly to OCD, when we as a society throw around the word, oh my gosh, I'm so OCD about that. Because you wouldn't say that if you really had OCD. It's crippling. It's debilitating. You might go back and check that you've turned off the stove and then go to work or go to school. But someone with OCD, that can take hours, the checking and the rechecking. So we really need to do better as a society to stop stigmatizing mental health and to stop throwing words out like, oh my gosh, I'm so OCD about whatever. And so if you've done that in the past, like, don't beat yourself up for it because you weren't aware of it. But now that you're in psychology class and you're watching this video, you have more knowledge and you don't know who around you is dealing with OCD. And so you really need to be careful with your word choices. So moving on. So OCD is unwanted repetitive thoughts. And those unwanted repetitive thoughts are called obsessions. And the actions in the disorder are called compulsions. So let's look over here at this image on the right. So we have an obsessive thought, perhaps about germs, and that causes anxiety. And then anxiety gets so extreme that we want to do something to reduce it. And so we go and we scrub our hands really well under the sink and we experience relief. But the problem with OCD is that cycle just keeps continuing or it builds up. So now what was 1 bar of soap, well, now I have to do a 2nd bar of soap. Like, it kind of builds and builds, and these can be very time-consuming tasks, these compulsions. And for maybe short-term relief before the obsessions start again. It's more common in teens and young adults than older adults. And here are some of the more common obsessions and compulsions. So post-traumatic stress disorder is haunting memories, nightmares, social withdrawal, getting really jumpy or anxious, a numbness of feelings, sometimes insomnia that goes along with those nightmares. And they have to linger for 4 weeks or more for the diagnosis. It's more about the reaction and the memory of the trauma than the trauma. Most people who experience trauma do not have PTSD as a result. 1 in 10 women and 1 in 20 men who have experienced trauma have PTSD. 1 in 10 women, 1 in 20 men. So most people don't get PTSD. Natural disasters, sexual assault, any sort of medical trauma, obviously combat, like there a huge list of things that could cause it, because like I said, it's more about your brain's response than the actual particular event. And our brains are hardwired for this. We have flashbulb memory that helps us remember all of the details of a specific traumatic event. And that was a survival factor for our brain that can kind of cause problems when it leads to things like PTSD. So what are the causes of it? Well, we know that there is a genetic link. We know that some people have a more sensitive limbic system, and that can cause an increased risk of PTSD. We know that getting people to relive their experiences after trauma can actually sometimes lead to more harm than good. And no, it seems like people say like, oh, let's, you should talk about it and get out there. But really be careful with someone who's experienced trauma that they should really be doing that on their own terms or with a professional who can guide them carefully through without re-traumatizing them. So like I said, most people who experience trauma do not experience PTSD. And so positive psychology has found that there's benefits to being resilient and surviving through trauma. And that is that people find more meaning in life, they have a new appreciation for it, stronger connections with people, and the way they deal with life. So post-traumatic growth, and that should be bolded and underlined. Apologize for that. So there are many underlying connections to anxiety and all of the other terms we've learned in previous units. So for example, classical conditioning, if a child becomes afraid of a wooden spoon because they've been hit with it frequently, then that neutral stimulus of a wooden spoon is now a conditioned stimulus and causes a fear reaction. And you can apply this to anxiety in a whole bunch of different ways. Someone being afraid of taking a test and then seeing a test or a Scantron looking sheet or whatever. There's also generalization that can take hold, and also reinforcement. Someone who's avoiding school stays home and their anxiety is reduced. That is reinforcing the behavior to stay home to reduce that anxiety. And so it kind of prolongs that experience. Observational learning also plays a role where people can just learn by witnessing other people experiencing anxiety and then become anxious because of it. Your friend might be anxious about a presentation in class, and they're so anxious about it, and witnessing them go through it, that you become anxious about your presentation. And then, of course, there are our thoughts. Cognition plays an important role. And there's something called cognitive behavioral therapy, and that's really one of the most effective types of therapy for people with anxiety disorders. And that's because the root of anxiety are these irrational beliefs that we don't know how to control or get away from. And so CBT helps us change our thoughts to help us feel better. There's also evolutionary relevant fears like fear of snakes, fear of heights, but some we don't fear because they're not evolutionary relevant. Like people actually became desensitized to planes flying overhead during air raids. You'd think they'd become more afraid, but that's not something that our brain is hardwired to fear. Compulsive acts that occur with OCD are typically, but not always, related to survival things. So like the hand washing, for example. We know that genes matter, and serotonin plays a role, and glutamate plays a role. It's been linked to our brain's alarm reaction system. So too much glutamate is sending our alarm, our sympathetic nervous system, into overdrive. And there's something called the anterior cingulate cortex in the brain, And this part of the brain is known to be important for regulating our checking for errors. And so it's especially active in those with OCD. So our takeaways, remember there's a big difference between having normal feelings of anxiety or wanting things a particular way and having a disorder. Remember, for OCD, the compulsion is the behavior to reduce the anxiety, and the obsession is the obsessive thought. OCD and PTSD are not categorized as anxiety disorders. They are separate. Most people who experience trauma do not have PTSD. In fact, some have post-traumatic growth. Anxiety, OCD, PTSD have genetic links. They have links to learning skills that we've discussed, and they all play a role. And the rates of generalized anxiety disorder and OCD dramatically decline in older adulthood. So that rounds up Mod 66, and I will see you in class. Thanks, guys.